So triplet therapy, do you pick your oral agent based on the data? What do you use to sort of pick when you know you're going to use triplet? Any insights? Or does it matter?
I think the question is, to me at least, when do we use triplet therapy and what is the appropriate situation?
Yeah.
Obviously, there was the 2 trials that involved abiraterone plus docetaxel and darolutamide plus docetaxel, which showed a benefit of adding the androgen receptor modulator to the docetaxel. But the question is what patients really need to be on the addition of docetaxel when they're already going to be on the androgen receptor, the oral agent? And that question was not really answered in either of those studies. That being said, for somebody who has high volume disease, as Phoebe mentioned, and who is young and otherwise healthy, I will definitely talk to them about triplet therapy. And if that is a consideration for that patient, then I would choose one of the 2 androgen receptor modulators that had been shown to show benefit with docetaxel.
Yeah, I mean, I think I'd take a similar approach. You know, I really, those trials you mentioned, you know, I think they were structured the way they were because a lot of it was in Europe. So like us in the States, you know, we would prefer to have the opposite design. Yeah. So ADT plus ARPI plus or minus docetaxel as opposed to ADT plus docetaxel plus or minus ARPI. You know, probably we're never going to have that answer. But it would be great if we did. But so yeah, I certainly for a younger, fitter patient, high volume, offer docetaxel. You know, the triplet I probably use more darolutamide than
just less toxic
because it's usually a little bit better tolerated.
My impression when you know, and I don't treat these patients, right? But my impression when I look at the data nationally, that patients aren't even getting doublet therapy, let alone triplet therapy, right? And so it seems like triplet may be pie in the sky to me that for a very finite population. But it seems like the need is really to educate around, let's at least be giving doublet therapy for patients who need it.
I think it's like 60% or something.
Well, that is changing.
You think it's going up?
I think it's improved, but I would hope so. But yeah. Okay.
There was an interesting meta-analysis in JAMA Oncology in 2023, I think, that tried to look at some of this and look at whether there was comparing these groups from different trials to see if there was really a benefit. And most of the comparisons didn't show much of a benefit between the, androgen receptor modulator plus the docetaxel. But I think that question is still open. So.
Yeah. I mean, I feel like, and for a while we thought ARV7 would solve that question for us. And of course, that has not proven to be a valid biomarker to decide who goes on what therapy. What about, Bob, I was going to ask you, do you ever use the AI tool to decide who should not get ADT with your radiation?
So I think I have ordered the test. I think, you order tests that you have to sort of recognize the level of evidence that is now and the levels of evidence that hopefully we will generate in the future. I'm looking to Todd because he's been very involved in some of designing some of these studies. So
of course.
The cooperative groups, whether it's development of the genomic tests or the genomic classifiers, that is a lot of the high quality evidence has been generated from using specimens in randomized trials and then reanalyzing that data. And that's the same thing where some of the artificial intelligence tests have been, been reanalyzing those. And the extent that you see the addition of a prognostic biomarker, both of them have been shown prognostic. That's just another tool. That's like least score, that's like PSA. And so and I'm very willing to sort of use that into my calculus to sort of help figure out how good, poorly, or how well a patient's going to do. And you can sort of test those hypotheses in prospective randomized trials. When it's predictive biomarker, when it's truly should we do hormonal therapy or not at all, that to me is a little bit, it's super promising and there's great data, but it's also one that I'd like to see validated prospectively in the majority of cases because it is, in its truest sense, the predictive biomarker, you might be withholding a treatment that can benefit a patient, and if that patient has a poor prognosis, you're not doing any hormone therapy for them. So I think, particularly with predictive biomarkers, I like to see it prospectively validated. I don't know how you.
I mean, this is the challenge is that prognostic biomarkers are so much easier to develop.
Yeah.
We can use retrospective samples. The follow-up is baked in.
Yep.
They're important,
Yeah.
but they're not as important as predictive markers at the end of the day, right? They're actionable, we think, at times.
Right.
But just because somebody is considered high risk according to a biomarker does not necessarily imply a given treatment, as opposed to a predictive marker where you're tying the marker to the treatment, and there the bar is really high. We need a prospective trial. You need to show that in the biomarker positive population, treatment works. In the biomarker negative population, that treatment didn't work or isn't necessary. And so Bob, of course, is designing studies where we have active studies that we're accruing to through NRG, really important trials to answer these predictive marker questions.
I agree. Yeah. So prospective trials are still important for answering a question like this. But also what's changed from the retrospective data on which that is based on is, people are living longer. So, there we had our TOG trials. We had, 7-year disease-free survival and overall survival rates, which, if we talk about the case we presented, 62-year-old, 7 years later, that patient is still going to be not even 70, and you're still going to be faced with a number of dilemmas about how to treat it. Probably if you're completely on the fence with where other things like Gleason score and everything are not swaying you one way or the other, may be helpful, but I think that's correct.
And the other thing that I think some of the artificial intelligence tools, the genomic biomarkers, they do have clear roles in helping and assisting and standardizing the way that we're calling, pathology. And so I think that's a whole other area that's sort of tangential to here. But in my mind, when I hear, I'm glad you asked the question, artificial intelligence, with what? With prognosis, with standardizing a diagnosis, with predictive, and each one I think demands different levels of evidence. Each one demands different levels of answers. So
yeah, I must say it is easy to use though, because it's one slide that you can send versus waiting for tissue to be set out and all that.
And scalability, there's a lot of things.
Yeah, exactly. And maybe we need to use that in metastatic disease. We have not looked at that yet, but that may be something to delve into.